Well, if you look at every industry, the way advances happen is through technology. Now, I want to be clear, it's not the technology alone, it's the application of that technology through skilled leadership. It's systematic improvements, operational excellence, but foundationally, technology has been across really centuries the driving force for advancement. In medicine, that hasn't been the case. Yes, we have a lot of technology, but most of the technology that's been introduced, let's say, over the past 25 years, has been very interventional specific. It's not been technology to move an entire industry.
This is Dr. Chethan Sathya. Thank you for joining us for this episode of Northwell Health's 20-Minute Health Talk. Today, I'm joined by Dr. Robert Pearl. He is the author of the recent book, ChatGPT, MD, former CEO of Kaiser Permanente, and currently a professor at Stanford's Business and Medical School. Robert, thank you for being here with us today.
It's my pleasure to be with you. I follow your health system closely and have a tremendous respect for the success that you're having.
We really do appreciate having you on, and you've done incredible work across many, many spaces. So excited to kind of chat with you. And you have some Long Island roots.
I do. I grew up in Great Neck. I'm a big runner, so I'd run by the hospital just about every single day. And also when I was in college, I had a chance. My uncle was a surgeon at North Shore Hospital, and I had the chance to go to the operating room with him and increase my interest in medicine for the future.
Wow. What type of surgeon was he?
He was a general surgeon. I got to watch a cholecystectomy that day, and I was very impressed by how in a very short amount of time, a patient who was suffering tremendous pain and at risk of potentially dying could have their life completely changed and have their problem reversed.
It's incredible. It's incredible. You know, it's so interesting. I'm not from Long Island, but I find more and more increasingly, there are so many people who came from here and have some sort of connection with Long Island. So it's really incredible. I mean, it happens multiple times per day.
Yeah, well, after I went to medical school at Yale, I went out for a residency at Stanford, and a whole lot of people from New York who come to California actually never leave, like myself.
Yeah. How can you? I mean, the weather looks incredible. So, you know, you've had an illustrious career, so many different hats. You started off your career as a plastic surgeon, right? And you were doing cleft palate.
Cleft lip and cleft palate was my area of big focus, did over 1,000 cases, did a lot of mission trips. I really loved, again, the opportunity to be able to take a patient who would never have a positive life, couldn't have a successful career often, couldn't have a good marriage, and in a very short amount of time, be able to reverse their fortune and give them the kind of fulfillment that we all desire for ourselves and our family.
It's such a rewarding part of the work we do. You know, after being a plastic surgeon, of course, fast forwarding a little bit, you went on to be the CEO of Kaiser Permanente. You know, what was a pivotal moment for you as a practicing surgeon, physician, that kind of said you want to do more at the systems level?
It was an evolutionary process. I did my residency, as I said, at Stanford, and a lot of happenstance, serendipity. As a chief resident, I was actually planning to go to South America and fix kids with cleft lip and cleft palate for a year. And the plastic surgeon at Kaiser Santa Clara died in a tragic plane crash. And they needed someone to fill in for 6 months. And I said, okay, I'll fill in for 6 months. I mean, I didn't have a specific problem. I didn't have a specific plan. And it seemed just as good. I'd never heard of Kaiser Permanente at the time. And I got there and I loved it a lot. And I kept staying on. And it was interesting. After a year, they asked me whether I'd become the chairman of the operating room committee. A lot of responsibility. Things were in trouble at that time. We had a nursing shortage. There were delays in surgery being created as a consequence of that. I was sure the reason they asked me was because I had such an impressive CV. No, everyone else had said no. I was just the last guy, foolish enough, the newest rookie who would say yes to an opportunity. But I actually enjoyed it. And that started this transition for me during the time period, including being at Stanford Business School, and took on ever more greater responsibility. And the big issue came when the opening, well, actually 2 points. Number one, the head of the hospital had a problem with the surgery arena. He was a primary care physician. And he asked me whether I would take on the responsibility. And I loved clinical surgery. And I told him I would do it, but only if I could continue operating as his number two person. He said yes, he would do that. And then finally, when the top job in Kaiser Permanente opened up, they asked me whether I would be considered as a candidate for the role. It was not something that I thought I wanted to do. I was very happy in the roles that I had, in the administrative role and the surgical role that I had at Santa Clara. And I knew at that point that I'd have to cut way back, obviously, on any clinical work that I did. And I asked a couple of other people whether they would want the job. I would support them in that process. But when they said no, I didn't feel like I had a choice. Kaiser Permanente was in great trouble at that time. We were down to 2 days of cash. We had to borrow a day of cash to meet regulatory requirements. And I think people saw the job as being too big. And I knew that if I didn't step forward at that time, that I probably couldn't stay, because I didn't think the organization would be able to make the changes that were needed, the strategic changes, the operational changes. And so it was, you can call it an existential moment, but one that I did embrace and was glad that I did so.
So funny how things kind of work out, right? So it wasn't part of the game plan when you
it was not part of the game plan. I wanted to practice medicine. I loved doing surgery. I loved seeing families. After a while, I had been there for probably 15 years. I was operating not only on both the patients, but their children. And this opportunity to stay involved in making people's health and life better. I was loving it, and the opportunity to be able to do administration as well was very fulfilling. And this would be a major shift. So no, it was not the game plan that I had. And had either of the two individuals that I asked whether they would take on the role said yes to me, I probably would never become the CEO.
Wow, an important lesson, right? Don't shoot down opportunities until you really evaluate them, and it could absolutely be life-changing. You know, early on, you wrote a book called Mistreated, right, about our broken healthcare system. What inspired you to write that? You know, what were some of the examples that made you say, listen, like, this is, our healthcare system needs fixing?
Well, what made you write it was, I would call it objective analysis of our healthcare system. It most closely resembles the 19th century cottage industry. It's fragmented with clinicians spread across communities, unconnected with each other, unconnected with the hospitals where they work. It is paid on a piecemeal basis. We call it fee for service. The more you do, the more you get paid. Whether it does anything positive doesn't really matter. See a patient twice for a problem you can solve in one visit, and you get paid twice, even though the outcome is no better and often worse. And we use technology that's left over from the prior century, although really I should say from the 19th century. The most common way is, you know, that doctors exchange vital information is the fax machine, an 1834 invention. When I tell my students at the Stanford Graduate School of Business that this is the way that doctors in 2026 send information back and forth, they say to me, what's a fax machine? They have no idea what this technology could be. And so it was clear that unless we could improve the system of medicine, something you've done very, very well at Northwell, unless we could improve that system of medicine, we would never be able to provide the kind of excellence. And as we know, the problems were getting worse. Costs were becoming unaffordable. Quality has languished, with life expectancy no greater now than 15 years ago. And a crisis was coming at that point. And I wrote Mistreated to help people understand that we need to make system changes quickly. And I would say, unfortunately, I was not successful because the healthcare system has not evolved significantly over the past 10 years since that book was published.
But you're a big believer in integrated care, right? And you took some of those lessons and you tried to create change at Kaiser.
Yeah, I'm a big believer. And no, I would say I inherited the kind of model that I believe strongly in, left over actually from Dr. Sidney Garfield from 70, 80 years ago when he put it into place. The care is integrated. Primary care works with specialty care, inpatient works with outpatient care, insurance company works with the healthcare system, the medical group providing the direct care. It's paid on a capitated basis. At least 95% of the revenue comes through capitated contracts, both private and public. And the technology was advanced. We put in place, the first year that I was there, we put in place the electronic healthcare record, or at least started the process of doing so, and was able to move quality from being relatively middle of the pack to number one in the nation based upon the NCQA. And I give technology a major applaud for that accomplishment.
Talk to me about that. So you give technology a major nod for that. Yeah, drill down a little bit there.
Well, if you look at every industry, the way advances happen is through technology. Now, I want to be clear, it's not the technology alone, it's the application of that technology through skilled leadership. It's systematic improvements, operational excellence, but foundationally, technology has been across really centuries the driving force for advancement. In medicine, that hasn't been the case. Yes, we have a lot of technology, but most of the technology that's been introduced, let's say, over the past 25 years, has been very interventional specific. It's not been technology to move an entire industry. Now, I think the electronic health record should have been that. But it wasn't. Why wasn't it? Because it was created for billing and coding. It was created for economic reasons, not care delivery. And it's why I'm such an enthusiast today of generative AI, because I believe it has that possibility to do what has never been done before, to be able to address the cost challenges by raising quality and improving access. It has the ability to make medical care continuous, not to be episodic. It has the ability, I believe, to improve, to prevent 30 to 50% of heart attacks and strokes and kidney failures by better control of chronic disease based upon the data from the CDC. I think it could revolutionize and transform American medicine, but it's going to require that clinicians and hospital systems and medical groups be willing to not only embrace the technology, but to change the way that they do operations in order to achieve the benefits that the applications provide.
Yeah, so a lot of change to workflows, for true culture change and implementation there. So let's shift over to AI. I know you recently wrote a book, ChatGPT MD. Talk a little bit about that. I mean, was it your prior experiences with technology that kind of inspired you to write about that? I know you've been playing around with ChatGPT for a long time and been very involved in this space. What was the impetus for that book?
I would say that although I have been involved in technology ever since I was in high school, and I actually programmed computers over the summer to earn money for college ultimately, and then medical school, that I am objective about its success rates. I was actually a critic of many of the applications of tools like Watson, very powerful computer system, but I didn't believe that it would be successful in transforming medicine, not because it couldn't do it theoretically, but because the data in the electronic health record upon which it was being built, the data sets that it was using were not going to be good enough to provide this kind of objective, conclusive medical care, evidence-based medical care. November 30th of 2022, OpenAI releases ChatGPT. I'm impressed. I've never seen anything like it. And I don't mean necessarily what was out on day one. I could just see the evolution that would happen. A technology doubling in power every year would become 32 times more powerful within 5 years. And finally, the information I've been writing about, as you said, back in Mistreated, I wrote about the system being broken. I talked about being able to be integrated and being able to be paid on a capitated basis. But I realized that it wasn't going to happen without a tool that would allow us to lower costs by raising quality, not by limiting care, as so often is the outcome in an insurance system. And finally, this tool was here. And I said, I've got to write a book about this because I can see the future. I mean, that's what I teach strategy at the Stanford Business School. That's what I tell people. You've got to see something that isn't yet here before others do. And then you need the ability to communicate around it in a way that they can see it too. And so that was the goal that I had when I wrote the book. I published it early in 2023. And interestingly enough, at the time, I worried and people criticized that I was being too optimistic, that this tool was never going to be as good. It'd be another electronic health record. Yeah, it would be interesting, but it wasn't going to transform medicine. And I think in retrospect, I was overly conservative. I think what's happened over the past, I'll say 3 years, is what I expected would take 5 to 10.
Wow. Wow. I also recently heard that Anthropic was debating kind of entering the EHR space or disrupting that space.
Well, not only were they debating it, they and OpenAI have both done so. And it's interesting. Let's just take one example, which is management of chronic disease. Chronic disease accounts for the majority of what doctors do today. And much of it is algorithmic. And if you think about how are we going to reduce burnout, how are we going to be able to prevent 30-50% of heart attacks and strokes and kidney failures as a means to save lives, and also as a means, by the way, to make medical care affordable again for our nation? We're going to need tools that are going to allow us to better control it. As you well know, hypertension, the number one cause of strokes. We control it 50% of the time in the United States. Diabetes, major contributor to heart failure and heart attacks, kidney failure. We control it even less often than that. And so we have to ask ourselves, why? What is it about these conditions that make us be unsuccessful at accomplishing what we know is the right thing to do? There's universal agreement around that. And I think it's the fact that we're still having to manage it through a discontinuous methodology. You see someone with elevated blood pressure, you prescribe a medication, you see them back in 4 months. What happens in those time? We have no idea. We need to have tools that are going to be continuous. We have them now. We have monitors people can wear. We have home blood pressure cuffs. We have opportunities to be able to take that data and have it looked at all the time. But clinicians don't have the ability to do that or the time to do that. They have the ability, they don't have the time to do that. And this technology can look at it. And now we're looking at having an empowered patient who is capable, after 1 month with 100 readings, a first and second derivative analysis would tell us, is the patient getting better, and allow us to make changes. And interestingly enough, the state of Utah has now passed legislation that would permit a generative AI tool to monitor patients with chronic disease and to renew their medication.
Wow.
Getting into the question you're posing with an OpenAI or an Anthropic. Once they have the patient entering the data into the health system, and that could include not just what they have right now, which is information off of wearable, off of watches, smart watches, and other tools, but why not have this monitoring data being entered all the time? It's not very hard to see a leap whereby these tools could actually become the clinician. And if that were to happen, I think it's going to be a major improvement, both in the experience of patient care for the doctor as well as for the patient. Now, why do I say that? The biggest challenge in medicine today I see as being time, because time is what leads to cost inefficiency. And if these tools can now accomplish, just say 30% of what primary care does today, primary care clinicians could now use that added time in a couple of ways. First of all, to have a bit more time to reduce the burnout that they're experiencing. But number two, to invest in the people who have the worst problems that are unmanaged today, that are way out of control, that require a lot more than a 15 or 20-minute visit. And by the way, they're also going to be able to do a lot of the things that today they refer to as specialists. Yeah. And why do they refer to a specialist? Because they don't have the time. They could do the workup and they could do the management if it doesn't involve an intervention or a procedure, but they don't have the time. Now, all of a sudden, primary care is doing that. Now, all of a sudden, we're lowering the number of heart attacks and strokes and kidney failures. How does that change specialty care? Well, you might think on number one that, oh, it's a big problem because we're not going to have patients. But right now, the biggest challenge we have is a shortage of clinicians, particularly into the future. And now we have the opportunity to create, as you've done in Northwell, centers of excellence with enough clinicians and subspecialization to achieve superior outcomes at lower costs. This is what we've been trying to accomplish, and this generative AI tool, to me, has that potential to do so. If you look at the ATM, when it first came around, people were afraid to put money into it. They were afraid they would never see it again. And today we not only put money into the ATM, but we also do things electronically that prove as safe as when we see a bank teller. I think that's part of the transition. People are afraid because you should be afraid about losing your job and losing your income. And that's why I'm such a strong believer that it's got to be led by clinicians.
But we do hear a lot of resistance to AI and fear that it's going to replace jobs and so on. Do you think that's warranted, and how do you overcome that fear?
Well, first of all, there is a fear, and I think it's embedded in many ways into what's often called cognitive biases. The first thing is that we always worry more about a technology than we do about human error. We know that 400,000 Americans, as you implied, die every year from a misdiagnosis. Another 400,000 have chronic long-term disability as a consequence of a misdiagnosis. What we need to be asking ourselves, from my perspective, is, are these tools going to reduce or increase the number of people who die? In many ways, it's like self-driving cars. We know that self-driving cars are 9 times safer than human drivers. And today, 40 to 50,000 people die on the road every year in a traffic accident. And if it delivered at a national level, we could reduce that to 5,000. And yet I guarantee you what the media would scream, what people would say is 5,000 people are being killed by the technology, not that 40,000 lives are being saved. It's the same situation here. We start with an assumption that medicine is practiced perfectly. And you and I both know that's far from the case. Yeah. And so the first thing is overcoming our bias. I think in addition to that, we need to be able to recognize, if you look at the ATM, when it first came around, people were afraid to put money into it. They were afraid they would never see it again. And today we not only put money into the ATM, but we also do things electronically that prove as safe as when we see a bank teller. I think that's part of the transition. People are afraid because you should be afraid about losing your job and losing your income. And that's why I'm such a strong believer that it's got to be led by clinicians. Because if it's not being led by clinicians, one of two things will happen. Either it will be led by technology companies, and they are not going to put the patient first. They're going to put the sales, they're going to put the profits, they're going to put their business first ahead of the practice of medicine, not because they're bad people. Just that's what happens in the world that we have right now, the economic world that we have right now. And if for any reason they don't do it, and for any reason the technology doesn't get advanced, we're just going to see what we're seeing already. We're going to see restrictions. We're going to see rationing of healthcare. What's happening right now on the exchanges, where over 1 million people are dropping out because the Congress failed to increase the subsidy or maintain the subsidy for the premium support. We're seeing it in Medicaid. It's about to lose 8 or 9 million enrollees to the future, not being driven by rational healthcare issues, but simply by government financing, that we can't afford it. I think we're seeing strikes. You saw it in New York City. We're seeing it in California, where basically people are afraid that we're not going to be able to provide the care in a financially responsible type way. And what we're going to see as a consequence of that, we're seeing that with the teachers' union strike in San Francisco, with the number one issue being whether families of teachers would be able to get healthcare coverage under the contract. And we're going to see that in small businesses. I think people are seeing the risks through one lens, but they're missing the big picture, that if we don't make these changes now, both from a technological and from an operational piece, that what we're going to have is a true disaster in the future, and we're going to see a greater disruption. Now, can people get over their bias and over their fears? I don't know. But I do know that if it's not being led by clinicians now, someone else will take the mantle. Someone else will have the responsibility. and the results will be not as good as I believe they could be for both the providers of care and its recipients.
Yeah, we need to be a major part of this conversation and leading kind of this change. I love that analogy too around autonomous driving and autonomous vehicles and technology then being blamed for the 5,000 crashes that do happen versus the tens of thousands that happen now, or more. It's a great way to kind of frame it. What about governance when it comes to AI in health systems, right? This is an ongoing conversation. What should the governance be like around AI and how we use it, the ethics around it? What are some of your thoughts there?
This is an important question, and I think it's going to become even greater in the future. And the reason I say that is what's called vibe coding. I don't know if you know what vibe coding is, but if you go back a year ago and you wanted to create a specific application, you'd have to have a tremendous coding background. I'm sure Northwell has lots of computer engineers who do this on your behalf. But the typical clinician in the community doesn't have that ability to do so. So they're handing out brochures and type material, not personalized to their practice and not likely going to be able to drive the improvements and outcomes that are going to be so necessary. Now it's a year later, and what we have is vibe coding that allows you to create code, specific code for your practice using simple English language. The key to this is no longer having a computer background. It's the ability to clearly explain what you need the tool to do and to then be able to make improvements using your voice, using English language, not requiring a technical background in coding. And this, I think, is going to be the next level of evolution. So the question is going to be, how do you regulate it? Because you can't really regulate a generative AI tool. If we had a lot more time, we could talk about the difference between narrow AI and generative AI. Narrow AI tools, the traditional way that you look at 10,000 mammograms, 5,000 show cancer, 5,000 don't, and you train a model to read x-rays, that doesn't apply in a generative AI world. These tools are trained on the totality of information, every medical textbook, every journal article, and they generate an answer that is unique for every individual. And so you can't regulate it in the traditional way. And I love the way you phrased it, because what needs to be regulated is at the system level. And I think we need to regulate it the same way we regulate everything, by which I mean, does it improve outcomes or not? Mm-hmm. How do we do clinical trials? Take two populations and have one of them managed by clinicians and one managed with a generative AI tool and ask who gets the better outcome. And if the answer is the technology, not only do we approve the technology, but we insist that humans move into the technology. And if it's not as good and better, then we don't do that. And I trust leaders like yourself and your quality experts and the other individuals in your health system to make those determinations more than I trust some external body to be able to look at it. And I think what we're going to find is that the outcomes are actually going to be as good or better. Now, the most, to me, interesting part or next phase, which I think very much applies to Northwell, because you are a health system, is how do we take these models, the large language models, we're talking about the ChatGPT and the Claudes and the Gemini, and now train them up using actual human data. Mm-hmm. How do we take the advice centers that patients call to and take a large language model, distill the healthcare aspects from it, and then train it on the conversations that happen so that everyone having that interaction now, having it with a technological tool, will actually match the performance of the best person in the advice center or the best person in the chronic disease management center. And by the way, most health systems are using an ambient AI listening tool. And how do we use that technology and that interaction to now train it up? We are at the dawn of what generative AI can do. If we adequately train it 5 years from now, we'll have far more powerful tools. And it wouldn't surprise me if over the course of time, we can train it on data off of operative robots to allow a generative AI tool to do many of the procedures that today are being done by humans and make this technology available in rural areas and underserved communities. As I say, we are just the dawn of what generative AI can do. I think the mistake we make is to look at what exists today. We need to be looking at what's going to exist in the near future. And by near future, I mean 3 to 5 years from now.
And have that vision. Yeah, I mean, I think even when it comes to surgeons like us, right, proceduralists, I mean, if you look at some of the new robotics and their ability to do microvascular stitches and so on, I mean, it's incredible. And there's tremendous variability across surgeons. And so, us embracing that, I think, is important. I know Elon made some controversial comments recently about Optimus and what they may or may not be able to do. And while I don't agree with the timeline necessarily, I do think it's going to happen. And I think we need to embrace it. I agree with you. I think it's a very exciting time because for once, at least the first time in my career, which is relatively shorter, I feel like we actually have an opportunity to transform the way we offer care, like really transform those workflows, right? I heard someone giving a talk recently and they said, if you look at what telehealth did during COVID, it didn't really change that much, which I agree. Our basic interactions with patients, I would argue, have not changed that much in the last 100 years, right? There are little adjuncts here and there, but we haven't fundamentally changed that. And all the stuff you're bringing up, wearables, continuous monitoring, AI decision-making, procedural opportunities in rural communities, I think that's the way that things are really going to transform.
Early on, after I published the book, I was on a podcast like this one.
Yeah.
And at the end of the show, when the recording was off, the host said to me, "Dr. Pearl, you're a big skier and you're also a physician. My husband fell 3 months ago. His arm was over his head. He slid about 100 feet down the mountain and his shoulder still hurts a lot. He can't use that arm as well as the other side. What's going on?" And I said, "You said to me that you had not used the generative AI tool during the program. Why don't you put the information into," at that time, ChatGPT was the only tool available because it was very early after the release, "and then give me a call and I'll tell you what I think." She called me 5 days later. She said, "ChatGPT said he probably had a rotator cuff tear." And it provided me with a diagram and other information about what the rotator cuff was.
Yeah.
It said he probably needs to have an MRI because that's how you establish the diagnosis. And we should consult a orthopedic surgeon because he almost definitely needed an operative procedure. Now compare that to the search engines at the time that would give you a long list of links that could be done. But what was interesting to me is what she said next. When we went to the doctor and he said, he probably has a rotator cuff tear, we knew what the rotator cuff was.
Yes.
We could ask key questions about it. When he said that we needed to have an MRI, we didn't question that decision. We knew exactly what was going on. And when after surgery, he said, "Had you waited 3 more months, I probably could not have reattached the tendon because the muscle would have contracted." We were glad that we did that. The reality is 240 million people every week use ChatGPT globally. I saw a survey yesterday that said that 40% of patients consult generative AI tools before they come to the clinician today, and 20% of people use it to replace coming to the physician. This is what is happening. And yet medicine is still debating about, well, should it, shouldn't, how good is it? We need to understand where the patient is today and not believe that we have the ability to stop people from using it, but ask, how do we use something like vibe coding? Or how do we provide instructions? Or how does the Northwell system educate all of the many millions of patients you take care of across your 26 hospitals so that they all come to surgery better prepared, so they all recover better after surgery using a generative AI tool that's going to be in their home? How do we move to hospital at home? And I don't know exactly how you see that as opportunity, but certainly there are patients who would do better in the confines of their own domicile rather than being admitted into an inpatient facility. How do we accomplish all these things using the tool? Because I'll say it again, if we don't do it as clinicians, as healthcare experts, someone else is going to do it. Mm-hmm. And if they do it, they will not do it as well as we would have. But once they've done it, we will not be able to reverse the direction that they have taken the technology.
Such huge opportunities. Huge opportunities. And I agree. I mean, listen, the consumer being the patient here, they're embracing it, right? And we are too. I think we are across administrative tasks and other tasks. And I think we can't have a reluctance to embrace it in our clinical decision making and how we rethink preparing patients. I love that. And I think it's going to take really transformational thinking to lead in that space. So Dr. Pearl, we're so thankful for your time. This was an incredible conversation. We're going to end with some just rapid fire questions, just to get your take. I'm sure you love these. But just very short answers. What's one healthcare innovation that excites you most? Probably what we talked
Generative
about.
AI.
Yeah. That was the whole podcast right there.
That was an easy one.
What's one health What's one health technology that you think is overhyped? Or are they all worth the hype?
No, I think I'm going to say operative robot. And I only say that because I think many clinicians are looking for applications of the technology rather than, as I believe, the process of innovation has to happen, which is to start with the problem and then figure out what solutions are available. So I think we're applying it in times and ways that are not necessarily leading to the best clinical outcomes and are certainly raising costs as a consequence of that. And so in that sense, you could say it's overhyped. In the right cases, it's fabulous. Mm-hmm. But I think in the cases that it's often being applied to, it's excessive.
Got it. And last one, what's one system globally that the US should learn from? One healthcare system.
I don't think there is a perfect system out there. One of the best is Singapore, mm-hmm. where I think they're achieving tremendous results at a much lower cost. I had the chance to keynote a conference in Zurich, Switzerland, where Switzerland is looking at how do they make the electronic health record information universally be available and then apply their technology to it. I would say it's a little bit like a smorgasbord. We have to take a piece here and a piece there. I think every country that has universal coverage, that's much better than the United States, where we still have 8 or 9% of our population uninsured. But I think we have a lot of things to learn. The data says that we are behind these other countries. Although we spend $15,000 a year per American, you have Switzerland at 11, Germany at 10, everyone else at half of our price. Our results lag in terms of life expectancy, maternal mortality, childhood death rates. We have a lot of opportunities, a lot of ways to learn. We need to have humility, and we need to have the ability to make the changes happen. I think the type of leadership that you've demonstrated, the type of leadership that you've encouraged in your organization is exactly what we need. We need leaders who are not afraid to make change happen. Great leaders can see opportunities before others. They can align people around it, motivate them to move forward. I think the organizations that do that at the national level will be the ones that everyone emulates, and there'll be tremendous first mover advantage.
Well said. Well said. Thank you so much, Dr. Pearl, for being with us today.
It's been my pleasure, and congratulations on your great organization.
Congratulations to you as well.